Hello, I'm Dr. Beth Mueller, and this is Intro to Maternity Care. It is topic 1.1 in Nursing 432. In this topic, we'll look at planning nursing care for the childbearing family. We'll look at contemporary issues and trends in family-centered nursing, look at kind of the journey over the last couple hundred years, examine health considerations related to the client with female reproductive needs, and also evaluate the concepts of contraception and infertility and family planning and how that has kind of evolved. So when we look at 21st century maternity nursing, um, that is what this course will cover is childbearing women and their families. So we'll look at preconception, which is prior to conceiving and conception, and then prenatal or antepartum period, which is the pregnancy. That's approximately 40 weeks. I know sometimes we say 9 months, but it's essentially like 10 4-week months. And then intrapartum, which is labor and birth, and then postpartum, which is birth to 6 weeks. So let's look at some of the advances in care over the last 150 years or so related to maternal child health. So in the early 1900s, so over 100 years ago, we started to see more standardized care for women in childbirth. There were some childbirth classes. There was the first milk bank where they actually kept supply of breast milk. Prior to this, there were things like wet nurses and things, but that was an actual first formal storage of breast milk. And then started to see some improvements in birth control and also feminine products. In the mid 1900s, there was the introduction of Lamaze education, which was formal childbirth education. Finally, got the birth control pill. There was more research on the causes of birth defects in the 1950s and 60s. A drug called thalidomide was widely spread use for treatment of morning sickness. It was this magic drug that was going to help all these women who were suffering from morning sickness. And unfortunately, I don't think it had ever even been through the FDA process. If it had, it wasn't approved, but it was still widely prescribed, and there were like 80,000 babies that were stillborn or died early, um, like like a premature birth, and then there were of those that actually survived to birth, there were over 20,000 that were born without limbs, severe nerve damage. It was just massive tragedy. And so they started doing more research on what is safe during pregnancy, what causes birth defects, all of those kind of things. Um, and don't get too caught in the weeds on a lot of this history. I'm just giving you kind of a background on it. Also in the mid 1900s, NACOG, which is the National Association of American College, or excuse me, the Nurses Association of American College of Obstetricians and Gynecologists. So OBGYNs are usually an ACOG, and then NACOG is the Nurses Association branch of that. Um, Also, in the mid 1900s, we started to see mammograms used to detect early detection of breast cancer. Late 1900s, we finally started to have home pregnancy kits. Um, Family medical leave was passed where if a woman was working and they had a baby, they could actually stay home and take care of it and not have to quit their job. Also, the Newborns and Mothers Health Act, which allowed for a minimum of 48 hours after a vaginal birth or 96 hours after a C-section of covered hospital care. Um, Also, and then there was also introduction of emergency contraception. And then in the early 2000s to current day, so the last 20 plus years or so, we saw the Affordable Care Act, which I'll talk about a little bit more in in another slide here. But um, honestly, not to tell you how old I am, but I was married when my husband was in college, and his first job when he graduated was up in the far north of North Dakota, and he got a job and had benefits, which was included health insurance. But because I was pregnant when he got that job, I could not be covered on his health insurance. We had to pay an astronomical amount out of our pocket when he was making like, I don't know, $6 an hour as a college graduate. Anyway, long story short, sort of, the Affordable Care Act, one of the things that um, came about from that is that they removed pregnancy as a pre-existing condition for coverage, healthcare coverage. Thank goodness. So, also we saw the emergence of the HPV vaccine, which helps protect against cervical and vaginal cancer, and also increasing research on the effects of viruses to fetuses and neonates. Okay, let's look at some health disparities. Our current data shows vulnerable populations such as women, racial and ethnic minorities, adolescent girls, or older women, incarcerated women, immigrants and refugees, homeless, and rural communities. All of those um, fall into that vulnerable population group, whether it be access to medical care, um, access to like um, health, healthy foods, food insecurity, all of those things can factor into vulnerable populations. And unfortunately, there is significant racial disparities as well. Um, my home state of Missouri, as of until a month ago when I moved, um, Black women faced a much higher risk of death than anyone non-white actually faced much greater risks of death um, with maternal morbidity and mortality. And in Missouri, it's very high. And we'll talk about some of the things that might impact that. Um, but honestly, over the last 2 decades, so the last 20 years, the maternal mortality rate in the US has like doubled. It's just very high. Um, and the US has the highest maternal mortality rate when compared with any other developed country, which is very sad. So, um, there are some efforts to reduce this. We have there's HRSA grants, which have health disparity collaboratives where they try to provide care for those who do not otherwise have healthcare coverage. There's the Office of Minority Health, which tries to prioritize those that are experiencing disparities. National Institutes of Health, there's specific research and education that is always continuing on, and they have a lot of resource materials as well. And then the CDC closely follows the trends of health disparities and inequities and measures the progress on elimination of those disparities. And also HHS, the Department of Health and Human Services, looks at reducing disparities through promoting evidence-based programs. If you've ever heard of the WIC program, Women's, Infants, and Children, where they get free healthy foods and education during their pregnancy and postpartum period, and then children up to age 5. And then also other integrated approaches and best practice to try and reduce the effects of those disparities. Um, Another group that, if you haven't already heard about it, I also teach 310, and I know we talk about Healthy People 2030 in there. Healthy People 2030 puts out science-based goals every 10 years, and the focus is to improve the health of Americans. And they have very specific maternal, fetal, and newborn goals, and they include like reducing the rate of fetal and newborn deaths, increasing the number of clients who attend childbirth classes because knowledge is power. It's important to educate people so they have the autonomy to make informed decisions regarding their health and their pregnancy and their birth process, and then always striving to reduce those maternal mortality rates, which unfortunately keep rising. There's also global goals with the UN, focusing on sustainable development goals throughout the world, and an overarching elimination of poverty and sustaining the environment, which seems pretty lofty, but we try. I just want to talk a little bit more about problems with the U.S. healthcare system, the structure of delivery. We have a lot of fragmented care where there's lack of coordination or collaboration among the different healthcare providers and organizations. We are trying to look at reducing those costs where we use managed care and integrated delivery systems to kind of help reduce that fragmented care. But it still may be expensive or really out of reach for many people that they don't have coverage. We also look at reducing medical errors. The Institute of Medicine does a lot of research on um, why an error occurred, analyze it, develop prevention strategies. Medical errors are the common major cause of death in the US, and uh, that can raise healthcare costs if because then insurance skyrockets because of errors, and it's just a big um, vicious cycle. So when we look at the higher costs of healthcare, the higher prices in general, um, readily accessible technology. As technology continues to change and grow, so do costs. Um, the use of midwives and APRNs or nurse practitioners have helped to lower the cost, but unfortunately, not all insurance companies provide reimbursement for those APRNs or nurse practitioners. Midwives have significant costs with their insurance, and that's why you have some of those small town doctors who used to maybe do a lot more deliveries, um, and they, deliver. I went to this, my mother went to this doctor when she had me, and now I go to this doctor with my pregnancy and blah, blah, blah. Um, if they don't do a lot of deliveries, it's very cost prohibitive to keep carrying that. Um, Labor and delivery insurance or the pregnancy insurance for providers. So um, we also have had limited access to care because people have the inability to pay, maybe lack of transportation and dependent childcare are barriers. If you're in a small town and the two providers that are in that small town have stopped doing labor and delivery, then you may have to travel 20, 30 minutes or an hour to get to someone who actually does prenatal care. And that can be a big burden. Also, there's a number of providers who maybe refuse to take Medicaid or only have a certain limited number of Medicaid patients they take at any given time. Um, so that is a serious issue as a significant proportion of births are to mothers who receive Medicaid. The health reform, I touched on the Affordable Care Act previously, and they kind of combine Patient Protection and Affordable Care Act. It has allowed insurance to be a little more accessible and affordable. Another benefit of Affordable Care Act was contraception was included without out of pocket costs to the consumer. More preventative services are covered, mammograms, well women visits with pap smears. screening for things like diabetes, breastfeeding equipment and counseling is now covered, and then again, that pregnancy not being considered a pre-existing condition. Some other contemporary issues and trends. When we look at low birth weight and preterm birth, there have been increased risk to morbidity and mortality with infants. A common indicator of adequacy of prenatal care and the health of the nation in general is included in those infant mortality rates. If they are getting higher, then that is a reflection of not adequate prenatal care and um, health problems in general in our nation. Again, disparities have increased between Black infants and non-white infants. Higher mortality and morbidity for those groups, and then we've had also birth defects, and then the preterm and low birth weight babies have also increased with the rates of morbidity and mortality, and pregnancy complications, SIDS, and other injuries. And then when we look at maternal mortality trends, the health disparities have a very strong connection to maternal death. Um, Also, other health issues, hypertensive disorders, cardiovascular and non-cardiovascular diseases, diabetes, infection, hemorrhage. And then when we look specifically at maternal morbidity related to specific factors, it could be related to acute renal failure. And all of these we will talk about in other topics, but I'm just touching on them, so don't get too in the weeds on this. But amniotic fluid embolism, and maybe other problems with pregnancy like preeclampsia, eclampsia, pulmonary embolism. There's a number of things that can contribute to maternal morbidity. Um, and then obesity it is one third, a little over a third of women in the U.S. Are considered obese, which is a BMI over 30, and that can be associated with hypertension or diabetes with pregnancy, and it can also impact fertility, congenital anomalies, miscarriage, and even fetal death. When we look at birthing practices, prenatal care, the when someone has regular prenatal care, we've seen the research, there's better pregnancy outcomes. There's earlier risk assessment, there's promoting of healthy behaviors, there's providing that education so people have the autonomy to make those informed decisions regarding their health and care. Um, we have primary care providers, which may be MDs, OBGYNs, MDs, like family med, certified midwives, that makes up a pretty small percentage, only about 8% now. Um, they also have doctors of osteopathy or DOs. Um, and then when we look at birth options, people have the option, depending on where you live, maybe to go to a birth center within a hospital. There are standalone birthing centers that provide a little more options and often have midwives staffed at them. And then we've seen a rise in home births with either a midwife or a doula at the bedside. And family-centered care, when we look at this, um, that is again, often a home birth, or sometimes in those standalone birthing centers, they have family-centered care where the partners, the siblings, the extended family, everyone that wants to be present is present. They can assist with the delivery. There's skin to skin immediately after birth is it's strongly encouraged, but a lot of in hospitals try to do that as well. There's evidence-based practice that skin to skin is so beneficial. And then we also see rooming in for the most part in hospitals and birthing centers where neonates often remain in the room with their parents and may never transfer to the nursery unless there's some medical issue. Often they have where you labor and deliver in the same room and then you just stay in that room, but not always. Sometimes you have to move to a different room. But anyway, so we do sometimes see early discharge, or because we sometimes have early discharge, there may be home care, and there are grants and things that allow for a nurse to come into the home with those either people who request it or they feel like maybe they need some extra support, or just anyone that they feel um, maybe falls into a category that might be somewhat high risk. And it allows for efficient and focused teaching, which is very important, especially if someone's going home early. Okay, let's look at some trends in nursing practice. We have standards of practice and legal issues with relation to delivery of care. We've I want to say every week, it seems like we are always looking at ways to prevent errors. When those errors occur, Joint Commission will go in and investigate, as well as Institutes of Medicine, and that's how why we have a do not use list, or look-alike, sound-alike drugs, or whatever it may be. It also, we have some standards per nurse specialty. We have ANA, we have A1, um, we have ACNM, NAN, all of those. Don't get too caught in the weeds on them. It's A1 is kind of like NACOG, but it's the Association of Women's Health Obstetric Neonatal Nurses. And ACNM is for nurse midwives. Let's see, NANN is for neonatal nurses. So there's all of those that have specialties that also research best practice and spread information to those nurse specialties. Sentinel events, as we look at trends, those are something that results in death or permanent harm or severe temporary harm. They're very acute adverse events that we try to do lots of research to identify what occurred so that we avoid those in the future. Um, then we have failure to rescue, which is just a failure to recognize or act on early signs of distress. And in the labor and delivery space, the intrapartum space, that is very important. We have careful surveillance and identification of complications, and then quick, appropriate action based on that. The team responds based on that. And that would be maternal complications like a problem with the placenta abruption, postpartum hemorrhage after delivery, uterine rupture during intrapartum, during labor, a number of other things, eclampsia, amniotic fluid, embolism. Again, don't get too caught in the weeds on those. We will discuss all those. Just be familiar that we have sentinel events, and then failure to rescue is not recognizing, oh, here's this fetal heart rate monitor strip, and the heart rate, the baby's trying to tell us based on the heart rate pattern that it's not getting enough um, oxygen, not enough exchange, and we don't act on that. So, standards of care for newborn for women and newborns, it's a little bit different than the typical ADPI. We just throw in after assessment and diagnosis, we do outcome identification, which is just identification of expected outcomes that are more individualized depending on that person and the state of the woman's care or the neonate's care, and then still the planning, implementation, and evaluation. Okay, so let's talk a little bit about ethical issues in perinatal nursing and women's health care. We have had so many technology and scientific advances, even in the last 25 years. And that um, includes advanced fertility treatments, chronic disease or illness and still able to carry a pregnancy. Um, your book presents a number of ethical issue questions like, should scarce resources be devoted to achieving pregnancies in older women? Is giving birth to a child at an older age worth the risks? Should older parents be encouraged to conceive a baby when they may not live to see the child reach to adulthood? Honestly, um, there are a number of ethical issues that get presented as we get more technologically advanced and able to do things. Ever since the first test tube baby, it has just grown and progressed. So those aren't anything we're going to solve or discuss even in this course. So um, we just want you to be aware that there are ethical issues as technology advances. Also, we do have something called age of viability, meaning the age that we do some sort of life-saving measures on a neonate or a fetus. And so currently that age of viability is 20 weeks. So if a woman is 19 and 2/7 weeks and starts to go into labor, chances are they will probably not do anything to stop that because that child and its chances to survive are very slim because they've determined that the current age of viability is 20 weeks. So don't get too caught in the weeds on that either. That is a discussion for another chapter, but I just wanted you to be aware of as we progress with honestly, when I was first a nurse, the age of viability when I was first in OB was like 25 weeks. And so someone prematurely delivered 23-week twins, we weren't allowed to do much for them other than keep them warm. We weren't allowed to do life-saving measures, which haunts my dreams now, but that's how it was back then. So anyway, all of those trends, as things change, they become more ethical discussions. Um, it is important that we provide informed consent, meaning that we provide education regarding options and allocation of resources and availability of resources and whether that be um, preconception, during this conception process, prenatal care, labor, delivery, all of those things. We need to make sure that we provide, we as healthcare professionals and the providers, we all, that the patient receives the important informed consent and information to make autonomous decisions. So, the family culture and home care. The family organization and structure typically say um, 50 or 100 years ago, it was a nuclear traditional family with a husband, wife, and children. That is steadily decreasing. We now see more multi-generational families, non-biologic parent families, married, blended, cohabitating, parent, single parent, LGBTQIA families. All of those have changed in what we picture now as as family. That traditional nuclear family now looks a lot differently than the way it did in previous decades or centuries. So when we look at theoretical approaches to understanding families and how families present themselves now, the perinatal nurse or the maternal child health nurse applies health promotion rather than an illness care model. We aren't doing that reactionary illness care. We are promoting health. We're giving it education. We're talking about preconception care and the importance of a healthy pregnancy and a healthy labor and delivery and all of those things. We look at the structural, developmental, and functional aspects of the family, the interaction of the individuals within the family, who makes up that family, who needs to be included in um, education, in teaching, all of that. The low risk family, we try to promote healthy birth outcomes so we have lower risks. And then with high risk families, we identify those risks and see if there are preventative measures and also any illness care needs that those families may have. Okay, one thing I didn't really touch on when I was talking about technology advances, when we look at theoretical approaches to understanding families, we now have genetic research. We have things that we are able to do that we can go more in depth into families and things that may affect health. And so this first image here is from your book. It is the family genogram and it depicts a family history. So um, they're able to look at the parents and their children and any health issues they have. It goes into a little more detail. Um, it shows that the grandfather had a heart attack. This person, this sibling was healthy, or whatever it may be. It goes into more detail, looking at connections. Were there multiples? Were there twins? Were there triplets? Um, was what did the family situation look like? How did it evolve? Were they married and then divorced? All of that goes into a family genogram. And then that echo map, it just describes the social relationships and looks at available support. So if you are a perinatal nurse and maybe you have someone who's in preterm labor and they need you need to identify now who in this family, if this patient goes home and is on bed rest, who's available, what does that look like as far as their social environment and any support systems? That's where that might get used. And then just real quick to touch on the family in a cultural context, this will be much more in depth as you get toward the end of this course and you do a cultural presentation on your assigned culture. So we want to always make sure with childbearing beliefs and practices that we're providing culturally competent care, respectful care, considering all aspects of culture that would go into our culture, including communication, space and time orientation, family roles. How do you communicate with your client? Do you need interpreters? Do you need translators that provide appropriate written education materials? And then looking at personal space, being aware of varied degrees of space. Some people want you right there. Other people need you at an arm's length. And lack of awareness can heighten someone's anxiety. If someone has a very broad area of space bubble and you're in their space bubble trying to help them labor breathe or whatever, that can heighten someone's anxiety. So the personal space also needs to be considered. Time orientation, orientation to past, present, future, that can greatly vary by culture. And it may be focused on day-to-day survival. If you have someone who's homeless or maybe doesn't have access to care for medical monetary reasons or whatever that may be, their time orientation, it may be just getting by whatever they have to do to get through the day. So all of that, the perinatal nurse needs to be aware of. And then again, family roles. What are the positions in the larger family? Are there any family roles that are affected by someone's social class or their cultural norms? Okay, that was a pretty brief overview of an introduction to maternity nursing. A lot of those topics we will go into more in-depth discussion as you progress through this course. But always, if you have questions, please reach out to your course and professor.